you all. I will present the findings of the study circulating levels of TRAIL and CRP in patients with chronic kidney disease of uncertain etiology. As we all know, CKDu is a global concern and it is mostly prevalent among the agricultural communities of rural dry zones. So, the key initiating factor is the sublethal renal tubular damage due to nephrotoxin exposure. And the gold standard biopsy revealed that tubular interstitial fibrosis with lymphocytic infiltration as the primary event. And when we have the magnitude of fibrosis and inflammation along with the disease severity, we could identify that fibrosis is prominent in early stages and it continuously rises throughout the disease. And when we assess the inflammation, there is evidence of persistent inflammation but no clear evidence of the magnitude of the inflammation with the disease severity. So in this particular research, we are going to assess two biomarkers. Those are highly correlated with fibrosis and inflammation. And the first one is TRAIL. TRAIL in the sense human necrosis factor related apoptosis inducing ligand. This is a human necrosis superfactor cytokine primarily produced by the immune cells, particularly the peripheral blood mononuclear cells. These can bind with 5 types of receptors. 2 of them are death receptors and 3 of them are decoreceptors. Once this ligand goes and binds with the death receptor, this will induce the cellular death that is known as apoptosis. And if it goes and binds with the decoy receptor, it will induce cellular senescence or apoptosis inhibition. The second biomarker we are going to discuss here is CRP, the well-known inflammatory biomarker. And as we all know, this is produced primarily by the liver in response to interleukin-6. The molecular format of this hepatic CRP is the pentameric form with identical 5 subunits, and it has anti-inflammatory activity. Once this pentameric form reaches a localized area like kidney, it is dissociated into monomeric CRP. And in addition, the resident macrophages also can produce monomeric CRP in the localized area. This has the inverse function when compared to the pentameric form. It has a pro-inflammatory activity. However, what we detect in our serum with the routine immunological assays is the pCRP form. So in this research, we are going to assess the circulating levels of TRAIL and CRP in chronic kidney disease of uncertain etiology and its relationship with the disease severity. For this, we conducted a cross-sectional study after obtaining the ethical clearance from Faculty of Medicine and Allied Sciences Laboratory, University of Sri Lanka. After obtaining the informed consent, we involved in screening and recruitment of the participants. Altogether, we included 47 confirmed cases of CKDu patients and 16 age and sex matched controls. In all of these participants, we measured serum creatinine values, CRP and soluble TRAIL. Serum creatinine levels was used to calculate the estimated glomerular filtration rate, thereby used for staging. When we go to the results, we could identify a significantly higher soluble TRAIL expression in CKDu patients compared to the healthy control. When we assess the distribution of TRAIL with the disease severity, we could identify a significant peak at stage 3A and a subsequent decline. When we assess the pairwise comparisons, we could identify a statistical significance between the control and stage 3A. And similar results was given in the CRP variation as well, because CRP levels in CKDu patients were significantly higher when compared to control, and there was also a significant peak at stage 3A and a subsequent decline as in the TRAIL levels. The pairwise comparisons here also reveals a statistically significant difference between the control and stage 3A. The most important part is how we can interpret this data. We all have seen that there is a peak TRAIL surge at stage 3A, and this might reflect the significant tibial injury and premature senescence. When tibial cells undergoes the senescence program, this will acquire a phenotype called senescent-associated secretory phenotype that can increasingly produce the intracellular matrix that will lead to fibrosis. The subsequent decline might be due to trail neutralization with the increased expression of the decoy receptors and also from the feedback inhibition. Coming back to the CRP levels again, we observed that there is a peak at stage 3A, and this might be due to the increased production of hepatic pentameric form of CRP, and this might be due to the surge of interleukin 6 in the intermediate stages of the CKDu patients that was found in previous studies. And subsequent decline might be due to the reduction in the interleukin 6 levels and also due to increased fibrosis that can affect the inflammatory process. But as I said in the introduction, there is persistent inflammation in the biopsy, and this might be due to more of the localized inflammatory response than the systemic activity. So we can conclude that serum TRAIL can be investigated as an early biomarker in CKDu, and stage 3A, 3B might be a therapeutic window. For further implications, we suggest in vitro mechanistic studies to identify the action of TRAIL in the fibrosis of CKDu and studies with larger cohorts. So if you need any clarifications, you can go through the references given here. And that's the end of my presentation. Thank you so much.